And welcome to the mid-morning session of Ascona III. I'm Emma Carrington, and actually this is Adil Bharucha, but we spoke in the last session, so hopefully you were there and listening to those lectures. I'm really excited by this next session, Assessment of Anal Sphincter Function. And we're going to start with Giulio Santoro from Treviso in Italy, who's one of the world's foremost experts in anorectal ultrasound. Welcome, Giulio.
Thank you, Emma, and thank you, Mark, for this kind invitation. So I have no intention to teach anything to such a very expert group of colorectal and gastroenterologists. These are my disclosure. But rather, I would like to review with you the anatomy of the anorectal anatomy and also the pelvic floor anatomy. So let's start with Mark. I'll try to do by myself. Okay, that's fine.
It's just it's supposed to be in the middle, but it always
okay.
out.
You have to push very slowly.
In the middle is this.
No, very slowly.
Just slowly.
Don't release somehow.
No, it doesn't like me either.
Okay, leave it as a projection. Leave it as a projection. No light on the screen. No light on the screen. Okay, leave it.
Go with dark.
Okay, with dark. Okay, with dark.
Don't like the light.
No, dark. Dark on the screen. Dark.
For filming, when you have the ultrasound images,
okay,
then
I will.
Adil will drop
That's right. That's okay.
the bottom button.
Okay, that's okay. So let's start with this review of the anatomy of the anal canal, and we know that the anal sphincters both are muscles, but are completely different kind of muscles, because the internal anal sphincter is a smooth muscle, is a thickness of the circular layer of the muscularis propria, whereas the external sphincter is a striated muscle. And in between the external and internal sphincter, we have another muscle, the longitudinal anal muscle, that is that derives from the longitudinal layer of the muscularis propria. Different kind of muscles, smooth and striated, different kind of innervation, because internal anal sphincter is supplied by the hypogastric plexus, parasympathetic and sympathetic fibers. The external sphincter has a somatic supply with the pudendal nerve, that is the major nerve that supplies the external sphincter, that originates from S2 to S4 foramina and runs through the Alcock canal. And it's important to remind that the pudendal nerve has three different branches: clitoral branch for the urethra, perineal branch for the perineum, and the inferior hemorrhoidal branch for the anal canal. And these three branches are very important when we use sacral nerve stimulation, because the sensory and motory response using sacral nerve stimulation, where we ask patients if they feel something or some sensation in the perineum, and if we can see the contractility of the anal sphincter, are due to these different branches of the pudendal nerve. And there is some difference regarding the distribution of the anal sphincters in the anal canal, because in the upper third of the anal canal we find the internal sphincter but not the external. In the middle part of the anal canal there is an overlapping of the internal and the external sphincter, and the lower third of the anal canal we cannot identify the internal sphincter anymore, but only the distal part of the external sphincter. So in the middle part of the anal canal, the internal and external sphincter forms these two rings for about 2 centimeters. The anal canal can be commonly divided in 3 different levels of assessment. In the upper level we have the puborectalis muscle and the internal sphincter. In the middle part, the 2 rings of the internal and external sphincters, and in the lower third, only the subcutaneous part of the external anal sphincter. Deeper part, superficial part, subcutaneous part. The deeper part is in continuity with the puborectalis muscle. Then we have the internal anal sphincter coming from the circular layer of the muscularis propria, and in between the longitudinal anal muscle. And also it's important to consider the difference between male and female, because these three components of the external sphincter, deep, superficial, and subcutaneous, are well represented in male, but not in female, where anteriorly in the anal canal, the deep, superficial, and subcutaneous part are fused and attached to the rectovaginal septum. And also the longitudinal muscle in the intersphincteric space is fused with another muscle, the pubioanalis muscle, that is one of the subdivisions of the levatorani, and the longitudinal muscle plus pubioanalis muscle forms the conjoined longitudinal layer. This layer is responsible for the movement upward and downward of the anal canal. And also, we must consider that the anal sphincter doesn't work in isolation, because the anal sphincter is in continuity with the pelvic floor muscles that are very complex. The levatorani muscle has three main components. The iliococcygeus is the deeper part of the levatorani. Then the pubococcygeus muscle is in the middle, and then more superficial, the puborectalis muscle. These three components of the levatorani also have different kind of functionality, because the iliococcygeus that has this horizontal distribution attaches laterally to the arcus tendinous levatorani and to the ischial spine, and is responsible to close the pelvic floor and also to sustain the pelvic organs. The pubococcygeus muscle, from the pubis to the coccyx, has a sphincter function, as a sphincter function as the puborectalis muscle. The iliococcygeus, with this horizontal and laterally distribution, close posteriorly the pelvic floor. The pubococcygeus has this anterior-posterior distribution and posteriorly forms what we call the levator plate. Levator plate is also very important because steadies and stabilizes the anterior rectal wall. And finally, we have the puborectalis muscle. Puborectalis muscle delimits the urogenital hiatus and also forms the anorectal angle. But levatorani has further subdivisions, because we can also identify the puboanalis component, the puboperinealis component, and also the pubovaginalis component. Why are these components important? The most important is the puboanalis muscle. So puboanalis is a striated muscle, part of the levatorani, and there's this distribution along the anterior and the lateral anal canal, and the puboanalis with the longitudinal muscles forms the conjoined longitudinal layer inside the intersphincteric space. What is the role of the puboanalis? Upward and downward movement of the anal canal. So let's go back to the anatomy. Iliococcygeus, deeper part, horizontal distribution. Pubococcygeus and puborectalis, sphincteric function. Puboanalis and puboperinealis, more superficial. Puboanalis is contributing to the movement of the anal canal. Puboperinealis is important to support the perineal body. We have so different kind of forces. Forward forces, puborectalis. Backward forces, the levator plate and pubococcygeus. Downward and upward forces, the conjoined longitudinal layer. How these different kind of forces work to regulate the anorectal closure? The anorectal closure, apart the function of the sphincter, is also due to the pubococcygeus muscle that steadies with the levator plate, the anterior wall of the rectum. The puborectalis muscle contracts forward against symphysis. The levator plate contracts backward against the pubourethral ligament to tension rectum, and the levator longitudinal muscle contracts downward against the uterosacral ligament to rotate rectum around a contracted puborectal muscle to close the anorectal angle. So the functionality and the anorectal closure is really multifactorial. And also we have additional muscles that are the superficial perineal muscle, the transverse perineal, the ischiocavernosus, the bulbus spongosus. And these muscles are important to form the perineal body that is considered, according to the classification of the Lenzi, as the distal vaginal support, or the Lenzi level 3. What forms the perineal body? Very complex structure with fibers coming from the external sphincter, the transverse perineal, the pubonalis and longitudinal muscle. All these fibers contribute to form the perineal body. How can we assess the anatomy of the anal canal? We have a great test that is endoanal ultrasound, and endoanal ultrasound provides a very nice imaging of the anatomy of the pelvic floor and of the anal canal. We use different kind of probes. We have mechanical rotating probes or linear array electronic probes. Both kind of probes also have special software for high-resolution 3D reconstruction. And we can see the different levels of the anatomy of the anal canal, the upper level with the puborectalis muscle, U-shape hyperechoic structure, the middle level with the internal and external sphincter, hyperechoic and hyperechoic. The lower level, you can see that there is no more internal sphincter in the lower part of the anal canal. Normal anatomy, you see the cadaveric dissection on this side and the ultrasonographic image on the other. And also we can have a volumetric reconstruction. Now I think I can reduce the light.
Yes, projection.
Projection. No. No. So we can have a volumetric reconstruction. Here is the puborectalis muscle. This is the middle part of the anal canal. And this is the wall anal canal with this kind of volumetric reconstruction. But we can even have more. Now the new kind of software allows for a tomographic ultrasound reconstruction like a CT scan, and we can visualize just in one image the lower, the middle, and the upper level of the anal canal. And we said that in female, the external sphincter is shorter anteriorly compared to posteriorly. We can measure the length of the sphincter in the sagittal plane or in the coronal plane, almost 2 centimeters. And look at the normal anatomy of the internal sphincter. We see that the internal sphincter is the border between the middle and the lower part of the anal canal. The longitudinal layer between the internal and the external sphincter. And as I told you before, the longitudinal layer is formed by the longitudinal muscle of the rectal wall plus the pubonalis muscles that are fused and forms the conjoined longitudinal layer. We can also visualize the perineal muscles. And also the new kind of software allows for elastography. And elastography provides also an functionality to understand the elasticity of the tissue. The internal sphincter is a more soft tissue compared to the external sphincter that is stronger with more connective tissue fibers. But also we can do a different kind of ultrasound, like endovaginal ultrasound, same probes. For what? To study the pelvic floor and the levator ani. This is the pelvic floor, cadaveric and histological dissection, and this is what we can see using endovaginal ultrasound. Symphysis pubis anteriorly, urethra, in the middle of the vagina. Posteriorly, we see the anal canal. And also, we can see the pubonalis attaching anterolaterally to the anal canal, and posteriorly the pubococcygeus and the iliococcygeus muscle. And this was validated with a cadaveric dissection. We published this study a few years ago. And we can measure the dimension of the levator hiatus, anterior posterior, the area of the levator hiatus. This is very important in female with the prolapse of the pelvic organs. And we can even visualize the superficial muscles. We published this study that was again a cadaveric dissection with the validation using ultrasound. And this is what we can see with endovaginal ultrasound, the bulbus spongiosus, transverse perineum, and the internal anal sphincter. Now, okay, very good and very nice image, but for what? For what we can use ultrasound to assess patients with incontinence as reported by the ICI in the 6th and 7th consultation. And an ultrasound has been and is the gold standard investigation in patients with the fecal incontinence. And we can very well assess OASIS, the obstetric anal sphincter injuries occurring in female due to obstetrical trauma. And these are some images. OASIS 3A means a superficial damage to the external sphincter. OASIS 3B, full thickness damage to the external but not to the internal. OASIS 3C, we have a damage involving both internal and external sphincter. And OASIS 4, there is a huge loss of tissue in the anterior part, also in the perineum. And using ultrasound, ICI proposed this algorithm for the surgical management of fecal incontinence, where ultrasound has a key and a central role in deciding the management strategy. In conclusion, anal sphincter anatomy and function. The internal and external anal sphincter have different anatomy and functionality. Anal sphincter do not work in isolation, but act with the pelvic floor muscles. The mechanism of anorectal closure is multifactorial, and the anal ultrasound is the gold standard modality for the evaluation of anal sphincters. And the vaginal ultrasound provides detailed imaging of the pelvic floor structures, and knowing normal anatomy is a prerequisite to understand abnormal. And let me to invite you to this afternoon. We will have a symposium in the afternoon, and the presentation will be on the role of 3D ultrasound focused on fecal incontinence. Thank you.
I'd like to invite some questions from the floor. Giuseppe.
What a surprise. It was a fabulous demonstration of the anatomy, though, Giulio, really. He paid me. He bought me a glass of Coke. So when I saw elastography, it reminds me of liver elastography. So it might be a naive question. There is any way that ultrasound can give us, I don't know, maybe in the future, some measurement of fibrosis or inflammatory activity, like it's possible for liver disease?
Yes, there are, thanks Giuseppe for your question. There are some studies published already. For brevity, I didn't include in this presentation, I will talk in the afternoon. Yes, elastography is able to assess and to check fibrosis, and this is very important even after repair of OASIS. So we do an overlapping repair, we do an end-to-end approximation, and after a time, we want to see if the fibrosis is okay, if the muscle is working, and elastography can help. And even we can use elastography, this is a different focus on tumor. So there are studies published on tumor to understand the elasticity of malignant tumor, of benign tumor, but this is in progress. So we don't have now enough data, and for this, in the guidelines and also in the recommendation of the society, there is no place for elastography, but only because we have no evidence so far. Few studies, but we hope that in the future, more studies coming, and this can be included in the workup. Yes, thanks.
Technology drives progress again. Any other questions? Yeah. Sorry.
Dr. Santoro, very nice presentation. My quick question is the role of 3D anal ultrasound in other structural aspects of anorectal anatomy, such as picking up rectoseals, enteroseals. You know, we're using a lot of tests. If we can simplify some of our testing, for example, defecography has become obsolete. I'm talking barium defecography, which would provide some insights before, largely replaced by MR defecography. MR defecography is clearly useful, but extraordinarily expensive. And it's done again in the lying position, which doesn't give us good physiological information. So I'm really trying to gain, you know, can we use the 3D to help us better understand? I know you've done some work in this area. Can you just share some of your experience and highlight
thanks.
Challenges?
Thanks. So my answer is no, not this kind of ultrasound. We proposed even a new terminology because we published a consensus paper on pelvic floor ultrasonography, and we defined a multimodality approach that we defined as integrated multi-compartmental ultrasonographic approach. What does it mean? That we have a combination of different ultrasound modality. Endoanal, I showed you endovaginal, but there is also a third modality, is a transperineal ultrasound, dynamic ultrasound. We use a different probe, it's a convex probe, positioned translabial, and we do a dynamic assessment of the pelvic organs. And transperineal ultrasound is a great modality to evaluate all kind of pelvic floor disorders, even dyssynergy or incoordination, where we compare angle at rest, during squeeze, during Valsalva, and so on, and what happens when ladies are contracting the pelvic floor or they are pushing down, and so on. So transperineal ultrasound is the modality that we should use in this kind of patient. The role, the defecography versus transperineal versus dynamic MRI. We published a Cochrane with the group of Abdul Sultan on the use of ultrasound in obstructed defecation. And at the conclusion of the study, we defined that transperineal ultrasound can be defined as the screening test, or as a triage test, and met the criteria to be a triage test. In the patient where is not enough, we can go as a second line, that is MRI or defecography. And because it's a procedure that we can do in our office, we can perform in pelvic floor disorders ultrasound, transperineal ultrasound, even combined to the other kind of endovaginal and endoanal. And if we have difficulties in assessing, we can ask for more. And I think that in the future, even the anorectal group and maybe even in the London Protocol, we can consider this new form of ultrasonography as a couple to manometry. Just to give you an example, in a female with oasis, to decide if female after an oasis can deliver with vaginal delivery or cesarean section, there is a protocol that uses manometry plus endoanal ultrasound. So how is important the integration of different modality? So really I hope that this transperineal ultrasound can be better introduced and more spread used by the clinicians, by us.
Two quick questions, quick answer.
Yes.
Remarkably comprehensive and lucid. So first is, you showed the actions of the individual muscles, right? Yeah. First question is, do you think that they work in concert, or do you think healthy people can activate them in isolation?
Never. Always in combination.
Very good. Second question is that when you see images, maybe ultrasound or MRI in patients, are you able to deduce which muscle is affected based on the abnormality of motion? Have you tried doing that?
I tried to do this, is a spoiler, this, because we have also another kind of possibility to use motion tracking, okay? As we use for the heart, to see the motion. So we tried to use this motion tracking to see, and there are like the weather report, where we see the arrows to understand if there is a storm or not. And yes, this is also in process to see the possibility to apply this kind of technology to understand the movement of the different muscle fibers.
Thank you.
Yeah, there is a lot. There is a lot. Thank you. Go ahead.
Sensational. Right.
And while Mark is loading up the slides, it's my absolute pleasure to introduce Corrine Légeret, who is a colleague of Mark Fotz's in Basel and a paediatric surgeon. Welcome, Corrine. The internal sphincter and Hirschprung's disease, 2022.
Okay. Thank you very much for having me. I'm a pediatric gastroenterologist, so I'm always a bit shy to speak in front of mainly adult gastroenterologists, but I realize it's a really nice group here, so thank you for having me. I talk about the Hirschprung disease, which is an inborn disease, and I just want to give you some insight on what is happening in the pediatric world of treating it, because at some point you take over the care of those patients. So we do know that Hirschprung disease manifests as a functional obstruction mainly in the neonatal period, and there are many diagnostic hints that we can use to make the diagnosis, but the gold standard still remains a full thickness rectal biopsy demonstrating the absence of the ganglion. Once we've made the diagnosis, the most commonly performed operations are the full thickness Swenson pull-through, we have it here on the left, or the endorectal Soave pull-through, and the retrorectal Duhamel pull-through. Individual studies have tried to show that there are different outcomes based on the different operation methods, but no superior method has been identified so far. All of the surgeries can also, there's always the option of laparoscopic assistance. Now, once the patient has undergone the surgery, the problem is not just solved, unfortunately. Now, this is the Nordic study group assessing the long-term outcome of pediatric patients with Hirschprung disease. They included 200 patients. The median age was 9.5 years. And as you can see here, only 37% of the patients reported that they have absolutely no impaired bowel function. 4% had a stoma, but the main population, or 42% of patients, suffered from constipation or a loss of fecal control. Here we have a meta-analysis including 600 patients. They were slightly older because the inclusion criteria was a minimum age of 10 years, but the numbers are really similar. So we have fecal incontinence in about 20% of the patient and constipation in 14%. Here we have another European study, and they compared adult patients to pediatric patients. And interestingly, they showed that adult patients more often experience straining and incomplete evacuation, and they had much lower rates of soiling compared to the children. So now we know that our patient with Hirschprung disease, it's most likely they will face some problems on the long term. So I think it's very important that we have a very systematic approach to the workup of those patients to make sure we identify those who benefit from further surgeries, and we support the other patient best possible. So different etiologies can lead to the main symptoms soiling and obstruction. So thinking of soiling, first of all, we have to make sure that it's a real incontinence and it's not a pseudo-incontinence. Is the patient suffering from an overflow incontinence? Has the patient hypermotility because the remaining rest of the colon is short and the patient lost the reservoir function of the colon? Does the patient have an abnormal sensation due to maybe the dentate line has been damaged? We can see it here. So the colonic mucosa of the pull-through reaches the skin, and therefore we lose the anal canal pressure. Is the patient suffering from near rectum insensitivity, or has the sphincter been damaged? Maybe during the surgery, or the patient has prior undergone myectomy or sphincterectomy. Thinking about obstructive symptoms, of course, as after any other surgery, we can have post-surgical problems such as strictures or adhesions. So we need to have a contrast study and make sure the patient's not suffering from this. Has the pull-through been twisted? Do we have an obstructing muscular cuff? That needs to be excluded. And then, of course, we need to take another set of biopsies and make sure that the whole aganglionic part of the colon has been removed, including the transition zone, and nothing really is left. And then always what pops up on those differential diagnoses is internal anal sphincter achalasia. And I just want to point out, or it's really important, that this is only a symptom and not a diagnosis in those patients, because the definition of anal sphincter achalasia is that those patients have a negative anorectal inhibitory reflex, but they do have ganglion cells on the rectal biopsies. So per definition, those patients can't have it, but maybe they have the symptoms that remind us of patients suffering from sphincter achalasia. And the pathophysiology of internal anal sphincter achalasia is not fully understood. We have several hints what might lead to the picture of it. And I know in adult care there's still the discussion going on whether those patients benefit from repeatedly having Botox injection versus myectomy, but this is really for adult patients. And then the main group that we have in pediatric gastroenterology is really the functional, the behavior ones, the ones that hold the stool back and therefore suffer from constipation. So lately, more and more case reports are being published, or studies where pediatric patients after Hirschprung disease are being treated with myectomy. And I just want to use this study as a sample. I talk you through. So this is a study where they included pediatric patient with Hirschprung disease who had undergone pull-through surgeries but still had problems, as we know is most likely to happen. So they suffered from constipation, from abdominal distension, and it says they did not respond to dilatation or drug treatment. All patients received a full workup. They received a barium enema, anorectal manometry, and they had a new set of rectal biopsies done. Afterwards, Botox was injected into the internal sphincter, everything very standardized. 1 week after the Botox injection, the manometry was repeated. patients who developed symptoms again after the injection of Botox. 3 months after having the injection, they received a second injection of Botox. If it was effective, but the patient developed symptoms again after 3 months, internal sphincteromectomy was performed. As we can see here now, also very standardized. Now, what I miss in this study or those kind of studies is there is absolutely no follow-up. What happens to the mean age was, I think, 6.5 years. What happens to those children after myectomy? What is the rate of soiling? What happens afterwards? And what I also miss is where is the education of the patient, completely resistance to drug treatment. I'm not quite sure, or when I start a discussion, maybe afterwards, whether this is the right way to go with those patients. Those are the results really that are being published. So we see that, of course, after the first injection of Botox, number of bowel movements increase, anal resting pressure decreases, clinical symptoms decrease as well. Of the 30 patients included, 12 received a second round of Botox. And here we have the same outcome. Number of bowel movements increase, anal resting pressure, and clinical symptoms decrease. And 11, so a third of all patients included, had a sphincteromectomy performed. And number of bowel movements, of course, increased, anal resting pressure and symptoms decreased. But again, that's the end of the story, so I don't know what the follow-up is, or no rates of soiling have been published. And so far, I think the numbers absolutely make sense that after Botox, after a myectomy, that we can reduce anal resting pressure. But then those are young children who have the whole life ahead of them. Also, what I want to make sure that we are all aware is that only because we have ganglion cells in the remaining rest of the colon doesn't mean, or we can't expect, a complete normal motility or function of this part of the colon. So we do know that there is an imbalanced expression of neurotransmitter, abnormalities of the smooth muscle cells, etc. So the remaining rest of the gastrointestinal tract does not have a normal motility. So as we can expect them, they need our support for the rest of their lives because there are some imbalances going on. And that's really the main discussion. I want to start whether myectomy is really the way to go in this patient, because we have absolutely no long-term experience what happens to them. So we work in our center much more with a biofeedback, and that's what I really miss in this study, because you have to imagine those children are 2 years old, 3 years old. They are absolutely traumatized because every doctor assesses their anus, all the examinations. Maybe they had a stoma before, so they need to learn the sensation of their body and react appropriately on that. Also have in mind, talking about children, that it's absolutely normal that an 8-year-old boy without any other underlying disease, once he has a tonsillitis, will say he's got abdominal pain. It's just they need to learn their body and what it feels and react on it. So I'm just saying performing surgeries is probably not the way that we need to go. Also, we do need psychological assistance for those children. They are traumatized, they are scared, they hold back, they use it as a behavior issue against the parents. This all increases the anal pressure. So just performing myectomy, I don't think that this is the answer to it. We need dietitians on board, and those children need to have a proper potty training. So these are the guidelines for the management of postoperative obstructive symptoms in children with Hirschprung disease. It's being published by the American Association of Pediatric Surgeons, and I'm very happy that I don't see any myectomies or the suggestions of myectomies on this, maybe yet. So we do actually see that it's being suggested that they undergo a motility workup. I like this slide even better. So this is from the pediatric surgical team from the Boston Children's Hospital. Very, very detailed what we should or how we should approach those children, and really having in mind if they don't learn how to feel their body and go to the toilet, at some point we will transition those patients with their problems into adult care. That's it. Thank you very much.
Thank you very much. Very nice. So whilst people are getting warmed up, one question, and that is that adult gastroenterologists, when the reflex, rectoanal inhibitory reflex is present, we say that that excludes Hirschsprung's disease, no need for biopsy. I didn't see that on your slides. Do you agree with that?
Well, mostly I have to say we do straightaway biopsies. We do it in clinic because our children are as young as 3 months, so we just do biopsies without anesthetic. So
okay,
it's a different approach.
Okay. So have you ever looked at your data? And are there data, for instance, showing that a biopsy may not show ganglion cells even when the reflex is present?
Yes, so those are the ultra-short Hirschsprungs that we, those patients that we meet when they're like 10 years old, or they're just really mainly older. Yes, absolutely.
Thank you.
This is actually how I got involved with the Children's Hospital, introducing the high-resolution anorectal manometry, which now, well, this is only one part of it, of course. The part is the functional constipation in the older children that Isabella, who is somewhere there, is running a study for with the UKBB zusammen. Yeah.
So I might just add, concerning biopsies, this is gold standard. So whatever you may find on manometry or may not find on manometry, if the symptoms are suggestive, at some point you will always have to do biopsies. And whether if the child's young enough to have them suction biopsies without sedation, well, then we go straight forward for those. But if the child will be older, what we often combine will be bowel management, and at some time they might have some sort of intervention in sedation, and then we do open biopsies. But I think bottom line is, if the symptoms are not explained by anything else, you will have to do them eventually.
I have a question. Oh,
go ahead.
Are you sure? I have a question. What a wonderful presentation, and interesting to me because I was originally a paediatric surgeon and now a functional colorectal surgeon, and I deal with the transition patients and the post-transition patients in my colorectal clinic. And it's interesting to me that absolutely, in my opinion, almost no data exists for outcomes as an adult. And I'm particularly interested in myomectomy, as you say. To what extent do you think this hypertonia is internal anal sphincter mediated? And if it is it necessary to perform a whole myomectomy? Because as an adult, if we were to have a patient, for example, with recurrent high-pressure anal canal, we would perform a lateral, theoretically, after we tried a number of things, we would perform a lateral sphincterotomy, which is partial division, leaving some of the internal anal sphincter intact, or indeed we would perform an anal advancement where we performed a lateral sphincterotomy and brought over some of the skin to actually maintain that anal contour. Have you got any experience of that being performed in the paediatric setting?
No. So we for sure don't do it in our center. And it's really something like a new trend starting, that they just go straight to surgery, which...
I'd be concerned about that as an adult. I mean, I have no experience at all in children, but my experience of adults who have a quite significant internal, an interlateral sphincterotomy, is that they often develop incontinence later in life, if not early on. So I can only imagine that your patients, it's a likelihood in the future.
Yeah.
And devastating.
There's one question at the back there. Oh, Satish. Sorry.
Just a short technical question. What's the maximal balloon volume that you use in a child with megarectum before you say the reflex is absent?
100. I mean, it is age dependent. Isabella might know there's a stepwise process. It has been published by a London group. I don't think it was Great Ormond Street.
So it really very much depends on the age. So in a infant, you will never go to 100. So the maximum you would use would be something.
Depend on the radiologic finding of the megarectum, for example. I mean, if you have a megarectum with a diameter of 10 centimeters, what does it happen?
Well, you wouldn't see that in the smaller. No, but
in the patients that we see as adults.
Okay, so no, I can answer that, and that would be then 400. I mean, if you've gone, I mean, the rectoanal inhibition reflex should be present at 100. That is the normal threshold. But if you really want to define megarectum, then the 95 cutoff is 400 mils. But that's independent of the rectoanal inhibition reflex. That is like 400, and I haven't really felt it yet. That is what we've published, and I don't know if Adil, do you have a different threshold?
No, I think that's fair, right? Yeah. Thank you.
So I was very pleased to hear that you recommend biofeedback as one of the key first therapeutic interventions in your patients with post-Hirschprung surgery and so on and so forth. So tell us a little bit about how you do the biofeedback, because it is often, I find that a little bit more challenging in this group of patients. So what kind of training do you do? Is it sensory training? Is it coordination training? Is it muscle strengthening training? Is it all of the above? Or really like to know what your experience is?
It's mostly coordination training, but first they really need psychologist support, because sometimes even if you open the pants, the pampers, they start crying and they are really, really, really traumatized. So that's why we say we work with them. We do have, or normally we admit them. It's a 2 weeks course really that they undergo, where they have intense psychologist support. Also, we teach the patient's parents, because they really cause the whole interaction problems, and then we can start working with them, and then they start really only sitting on the toilet, because most of them have a toilet phobia. Exactly. So it sounds a bit crazy, but those are really the first steps. We train them. And then they go on working with the biofeedback. And most of them, they need help with the coordination, because they have absolutely no idea what they are doing. They retain really all the time and are just being stressed. So it's really a whole program. And I think it's not only this part or this part that, is the key, really. I really think it's a multi-layer program that those children need. Because if they don't learn it by the age of 8 or 9 years, I'm quite sure they won't take the time later in life to focus on that issue and really train and work.
I mean, Corrine and her team really provided an amazing service. I mean, something that would be hard to conceive in England with a 2-week admission and so on. But it is a fantastic service that's offered. Thank you so much, Corrine. I'm delighted you could be here for us.
Thank you. Thank you. So the next talk is on new metrics for assessing anal sphincter function in the high-resolution era by Dr. Kee Wook Jung.
Okay, thank you, Drs. Fox, Rao, Scott, Carrington, and the Bharucha, the member of the anorectal dysfunction group, for this opportunity to speak in Ascona III meeting. I will talk about new metrics for assessing anal sphincter function in the high-resolution era. This is my disclosure. As we know, the method of anorectal manometry vary widely in clinical practice. Therefore, the London group made the new classification. I was one of them. I don't want to waste my time, the previously presented. And the previous used the conventional parameters, resting and squeezing pressure, as you can see, did not show significant difference among continent, incontinent patients and controls. This is the figure from the London's classification regarding disorders of rectal anal tone and contractility. However, London classification did not suggest a normal value for discrimination between continent and incontinent patients. We know there were changing concepts in the vigor of muscular contractility by the advance of technology. In the era of the conventional manometry, just amplitude was used. Sometimes area under the curve is used in the research level. However, Chicago classification changed everything. And they suggest a new parameter based on the multiplying pressure time distance, named as distal contractor integral. And they suggest as a new parameter to measure the vigor of muscular contractility. However, there was no validated robust parameter based on spatial temporal plots in anorectal high-resolution manometry. This kind of new parameter was suggested by London group with Dr. Emma Carrington and Mark Scott and Charles Knowles group. They enrolled 85 female healthy controls and 400 females with fecal incontinence. They used high-resolution anorectal manometry, and they measured the 3 parameters during squeezing: conventional anal manometry squeeze increment, high-resolution anal manometry squeeze increment, and high-resolution anal manometry contractor integral. As you can see, the noble parameters are made of multiplying amplitude, distance, and a certain time period, like DCI in esophageal high-resolution manometry. In their beautiful study, and they found that, as you can see, the green line is the contractor integral. The newly developed high-resolution anorectal manometry contractor integral increased the sensitivity of detection of anal hypocontractility compared with the conventional parameters. This is another representative figure of London's classification regarding the disorders of recto-anal coordination. As you can see, anorectal dyssynergia can be categorized based on the result of manometry finding as well as the Baldwin dispersion test. However, the classification of dyssynergia still adopted the previously used conventional parameters based on linear waves rather than spatial temporal plots from high-resolution manometry. This kind of currently using conventional parameters is that the dyssynergy pattern are commonly found even in the healthy volunteers, even up to 80%. This is the famous diagnostic criteria of dyssynergy defecation by Lomford. As you can see, during repeated attempts to defecate, there must be features of the impaired evacuation as demonstrated by the 2 out of the following 3 tests: A, abdominal Baldwin dispersion, B, abdominal anorectal evacuation pattern with manometry, or surface EMG, C, impaired rectal evacuation by defecography. However, one test cannot explain the result of other tests. Among these tests, at first, we try to make a novel parameter which can explain the result of Baldwin dispersion and the anorectal manometry finding as a one theory. In this study, based on asymptomatic healthy volunteers, we aim to make the novel parameter based on spatial temporal plots of high-resolution manometry, which can explain the result of Baldwin dispersion and manometry testing. During the push maneuver of anorectal manometry, we calculated by multiplying amplitude, distance, and a certain time period, like this, using the MATLAB after conversion to the ASCII file of raw data. We named as it integrated pressurized volume, aka IPV. We categorized them into 4 different ratios because we used the 4 directional sensors at the time with 1 centimeter intervals. Balloon dispersion tests were performed using 50 ml of water. The balloon used in the balloon dispersion test was composed of latex, and its length was 3 centimeter and the width was 1.5 centimeter. This slide shows you the result of that study based on asymptomatic healthy volunteers. We found that upper 1 centimeter versus lower 4 centimeter IPV ratio during push maneuver showed better prediction of a balloon dispersion test compared with the previously used conventional parameters, including the efficacy index or rectangular gradient. In this figure, as you can see, the balloon distension during the push maneuver showed a better prediction of a balloon expulsion compared with without the balloon distension during push maneuver. Therefore, we aim to investigate the usefulness of a new parameter in the constipated patients. We enrolled 200 male patients with chronic constipation and 20 asymptomatic healthy controls. They were categorized into early and delayed balloon dispersion tests. This slide shows you the representative images of early and delayed balloon dispersion using MATLAB. In this study, we also find that the IPV1-4 ratio showed a better prediction of balloon dispersion compared to the efficacy index. However, when we used the partial least scale regression model based on the multiple IPVs, we found the area under curve was up to 0.79. There was the effectiveness, a better prediction of the balloon dispersion projected result compared to the previously used efficacy index over IPV ratio. Interestingly, we also find that this kind of new parameters showed a better, good symptomatic correlation compared to the previously used the efficacy index. As you can see, the sensation of the anorectal obstruction or the hard stools showed a good correlation with the IPV ratio compared with the previously used the efficacy index. Therefore, as the IPV method can represent the pressurization along the entire anal canal, the result emphasized that novel parameters could be more physiologically relevant to patient symptoms, especially the feeling of anal canal obstruction over hard stools, than previously used conventional parameters. This is another study. We tried to investigate the role of IPVs in the prediction of responsiveness to biphasic therapy. In this study, we tried to investigate the predictive model of a biphasic therapy responsiveness based on 3D dimensional model in female patients with dyssynergification. We enrolled 71 female patients who underwent biphasic therapy. They were categorized into responder or non-responder group based on the result of the global bowel satisfaction score. In this study, as you can see, when we use the partial least scale regression model based on the 8 IPV parameters, the area under the curve showed improvement up to 0.84. However, when we use the 24 IPV parameters in this model, the area under the curve showed improvement up to 0.94. Therefore, IPV parameters were better than conventional parameters in predicting the responsiveness to biphasic therapy. And combination of these parameters and partial least scale regression model was particularly promising. Next is the unpublished new study, which was presented during DDW this year as oral presentation. We aim to make a new model using artificial intelligence for prediction of the delayed balloon dispersion test using highly reduced manometry data and IPVs. There were limitations of previous study. At first, we used just the 4 directional sensors without the use of circumference sensors. As we know, the London classification suggests the use of circumference sensors. The second is the direction of the axial force from leg to anal canal and its temporal change were not considered in the previous study. However, since the 2020, we began to use the circumference sensor. And moreover, we thought that AI model based on time series analysis might give us the answer. Okay, why do we need the time series analysis? This is the pitcher's motion of baseball play. The final trajectory, location, and speed of ball are dependent on the pitcher's whole series of motion, from wind-up, early cocking, stride, late cocking, acceleration, and follow-through. The previous motion affects the subsequent motions. Finally, all the motions from the wind-up to follow-through characterize the trajectory, location, and speed of ball. Like pitcher's ball, we cannot estimate the early or delayed balloon dispersion just based on the captured image of a specific time period. Therefore, we have to analyze the whole series of rectoanal canal motion based on time series analysis. 300 constituted patients were enrolled in this study, and they underwent both HRM and balloon dispersion test in Ascona Medical Center. The ratio of train and test set was 4:1. We used the circumference sensor in this study and analyzed them into 4 different ratios of IPBs like this. As I showed in the picture's motion, the time series is the time dependent. Therefore, long short-term memory networks are well suited to classifying, processing, and making predictions based on the time series data. This slide shows the method of this study. Using AI and the CNN and the bidirectional long short-term memory method was used in this study. Okay, let's make it simple. I made this slide for your easy understanding. Okay, left side is the early balloon and right side is the late balloon dispersion. Computer can generate the push motions of rectoanal canal based on time series like this. Just imagine, AI sees and learns the hundreds of different push motions based on time series over and over and again. Finally, AI can predict the result of balloon dispersion. I cannot show you whole data because this is still unpublished data. This slide shows the final simplified result of this study in male and female patients with constipation. The AUC of the AI model based on time series IPB showed a good prediction of up to 0.99 in male and the 0.98 in female patients, respectively, and showed better prediction of balloon dispersion than previously used defecation index. This is a demonstration of AI model with our TS-IPB. By click and direct the region of interest during push maneuver, we can convert the data into ASCII file. The data is saved as a text file. After the selection of the patient data, computer-generated AI model based on time series IPB in a very few seconds. As you can see, left side is 3D plot, the middle one is the mesh plot, and right side is the changing IPB ratio plot by the time. Okay, so after that, we have to select the gender because there is a gender difference. Okay, it can predict the early and delayed balloon dispersion test in a very few seconds. This is summary of our study. Our AI model was able to accurately classify the result of balloon dispersion test from low HRM data and time series IPB in both male and female patients over an AUC of up to 0.98. Furthermore, this model used the time variant HRM pressure data and time series IPBs throughout the entire time of the push maneuver without any data loss. It can be more reliable clinical marker to classify delayed balloon dispersion test compared to previously used conventional parameters. AI software can be conjunction with the currently using HRMD analysis system, and it can predict the balloon dispersion test using software in a very few seconds. However, this was already discussed before, that there are different catheters from different companies. They're using the different catheter sensing system as well as the different diameter and different channels. Therefore, normal value from different catheter systems vary widely. This table from the recently published review article shows that currently challenges to the high-resolution anorectal manometry. There are differences in the catheter design and pressure sensing technology among manufacturers. Therefore, patient data need to be compared to the technique-specific normal values. The Manoscan 3D probe is too rigid, much larger than the other probes, does not conform to the rectal anal angle. This may introduce artifacts. The normal values are unavailable or have not been assessed in a sufficient number of people. Therefore, absence of normal values substantially reduce the diagnostic utility of manometry. Finally, circumferential sensor topography needs further validation. And this is my final slide. This is my take-home message. HRRM based on spatial temporal plots look to be promising in the prediction of volume dispersion and biofeedback responsiveness. However, as you can see, HRRM still needs validation based on the large number of patients. AI model based on time series IPB utilizes temporal changes of HRM data during push maneuver. AI can have a role in the interpretation and classification of anorectal physiology studies. About 10 years ago, Dr. Lau visited to Korea. At the time, he was the president of MNS. I went to the airport to guide him because my boss told me to do that. Inside the van, because of terrible traffic jam, I had a chance to discuss my study about the IPB with the primitive data. And Dr. Lau gave me lots of advices, and I could make it with his help. Actually, IPB is not a new one. The concept of IPB is the progressed and modified version of the difficulty index based on the spatial temporal plots. I want to express my thanks to Dr. Lau. Thank you for your attention.
Giuseppe.
Giuseppe is a great.
I think that artificial intelligence is the future. I'm working with the Romanian guy on artificial intelligence for esophageal manometry. You will be surprised. It is much more simple, esophageal manometry and artificial intelligence. One thing, I think I understand your enthusiasm, but I think that needs to be tempered by the fact that, as far as I understood correctly, you don't have healthy volunteer. So if you don't have healthy volunteer, you know, healthy volunteer are even more relevant for the artificial intelligence interpretation than for human interpretation. So this is a missing point. And what I want to know is if you have any comparison for the symptoms in people that have normal balloon expulsion test or delayed balloon expulsion test, and you know, if there is any relationship with your finding with artificial intelligence.
Okay, I totally agree with your suggestion, Dr. Chialioni. So we are trying to do the more data based on the healthy volunteers, and I tried to gather more data, information, correlation between the symptoms as well as the AI model.
Rebecca Burgell, Melbourne, Australia. It's just such fascinating and interesting work, and having been in so many meetings, we've been banging our heads against walls on what metrics, particularly with defecation, are important here. The use of AI really moving away from kind of the difference between normal and abnormal, but focusing on predicting outcomes to treatment is going to be so critical, because as we talked about before, there's some patients that have got abnormal patterns in health, but it's whether we can find another metric that we have not picked up that predicts the outcome. That's going to be the really big game changer for me.
Thank you for your nice comments, and I totally agree with your suggestion. And we try to do the more data, applying the AI system to the biofeedback responsiveness and others.
Do you mind if I jump in and just ask a question related to Rebecca's? One thing that wasn't clear from your firstly, I absolutely love your work, and I really love the way that you have taken the physical motion, or the sequence of events, to be important, and I think that's what we've always been missing with our analysis to date. But one thing I can't get from your data is you talk about response to biofeedback, but in your prediction model, those who respond to biofeedback, how is their morphology compared with health? Are they the more abnormal patients, or are they the less abnormal patients, or do they have just a different pattern to those who don't respond? Because that is, I don't think you presented that data.
Actually, you're right, and you know that actually this is more complicated the concept in the finding that which factor is the more the better in the prediction of the biofluid therapy. There was thousands of papers, but did not show the robust finding. Actually, you told me that the same thing to the last week during the DW, and she was the chairman of this session, and after your inspiration, we're trying to do the more data.
Because if we go with response to biofeedback, for example, Rebecca, as our measure of it works or it doesn't, I worry that there may be other treatments which respond to other measures. It's not to say that a patient is abnormal who then responds to biofeedback. We have to be careful that we describe the whole process. And a patient might be responding to a different thing. We might be able to triage our patient different treatments. I'm very well aware of the fact that I have to say Walter has a question.
Thank you. I just have a question, very fascinating time series model. My understanding is that it's sort of a continuous model to predict the outcome. Have you been able to identify patterns of phenotypes based on these continuous models that might classify them rather than just using a continuous model?
Yes, that is another some kind of we have to solve that, because you know that means that maybe in the near future we have to learn from the AI which pattern is the really synergic or not, because the AI already gave the answer, but we do not know that by intuitively. So that maybe that may be the next the thing we have to solve.
Thank you very much.
Last talk of the session on 3D high-definition anorectal manometry, improved diagnostic capability by our dear friend, Dr. Enrique Coss-Adame from Mexico.
Sorry, I'm having... Yeah, no, it's already escaped. It's... Ah, there we go. Unresponsive mouse. Thank you, Adil and Emma, for kind presentation. Thank you, Mark, for the invitation to be here with you. And so I'm committed to talk about this 3D high-definition anorectal manometry and about what is the improved diagnostic capability that it can give us. The first, this is my speaker declarations, and this is how the flow of this lecture is going to be. So first, we're going to talk about what is this device, the impact in anorectal physiology, normative values that we have at this moment. What is the 3D high-definition anorectal manometry good for, and clinical utility? And is it better than high-resolution anorectal manometry? So let's sort this out. So first, we have to go back and remember the old technology, in which in conventional manometry we could see this beautiful increase in pressure during the squeeze and the changes in the anorectal region during the bearing down maneuver and the Valsalva maneuver. And these were possible because of this pull-through technique. And we have to remember that this technique had some cumbersome problems, like, for example, the artifacts that we could have once we were pulling through the catheter, and this movement could induce variation in pressure. But now with these beautiful plots that we have with the topography plots in high-resolution anorectal manometry, we can better define the upper and the distal margins of the anal sphincter, and we can combine at the same time the pressures from the rectum and the anal canal. And this is possible because of an increase on the number of sensors located in the anorectal catheters, as you can see in that one. But the 3D high definition anorectal manometry is something I think more aggressive, not in the number of sensors, but also in the kind of probe that we use, because it's a 10 centimeters length and almost 1 centimeter wide. So it has 250 pressure sensors circumferentially arrayed. So it can give us these beautiful 3D reconstructions of the pressure plots in the anal canals and give us a better way to understand how is the structures, the pressure structures in the anal canal. So what I really think this technology has provided us is a better impact in the understanding of anorectal physiology. So with these 3D topography plots, we can now have a better assessment of the anal physiology and the anatomical changes in healthy volunteers, but also in disease. So Ravi Mittal did this study for better characterize the sphincter using this technology. So here at your left, you can see the resting pressure. And so there is some differences in the anal canal, but once the patients, in this case, the healthy volunteer did a squeeze, you can see now that the posterior part of this topography plot, there is an increase and it's asymmetric. And this asymmetry is due to the location of the different structures, as we saw in Dr. Santoro lecture. With this ultrasound, we can see where is the location of the puborectalis, the external anal sphincter, and the internal anal sphincter. And making this interpolation, we can see how is the contribution of this pressure in the pressure plots. So the puborectalis is located precisely in the posterior and upper part of the anal canal, and gives more of this asymmetry in this component of the anal canal. And this is better understood once with this three-dimensional plot. So the forces once the subject is doing a squeeze is going up and back. So that is the reason how the anal canal is changing the position during this maneuver. So also Dr. Rao and his team has made this study for better characterize the rectoanal inhibitor reflex using this 3D technology. So here at left, you can see the resting pressure in the plot, and is corresponding with the resting state also in the old-fashioned lines. So once they inflate the balloon, there is a decrease in the pressure as is expected in the anal sphincter. But you can see that this decrease in pressure is asymmetric. It's not completely the same way in the entire anal canal. And it persists along the time. So the reason for that is that it changed, the morphology of this rectoanal inhibition changed with the volume that is infused in the balloon. So at lower volumes, the anal canal opens differently. So it opens up in the anterior and the posterior very similarly. But once they inflate the balloon with more volume, you can see that the posterior and the upper part of the anal canal open up in different way. And it's more profound. So that means that the more important part of the relaxation comes from the puborectalis and the internal anal sphincter. So they also describe this sensory motor response using this 3D technology. So at left, you can see the resting state, and then when they inflate the balloon, the rear comes up, and after inflating the balloon and reaching the threshold of decide to defecate, you can see that there is a contraction. It's an increase in the pressure in the part of in the puborectalis area and the external anal sphincter area. So that means that maybe this response is responsible to prevent leakage during the rectal anal sphincter inhibition once the contents are filling the rectum. So now let's talk about normative values. So there are some studies that have addressed this thing. The normative values are kind of different. So we did this study several years ago, and we found that compare males to females, males, they have higher pressures during the resting and during the squeeze pressures. And they also have more capability to have higher volumes during the rectal balloon inflation. We did this study in a repeat fashion in a subset of patients, and we found that the pressure acquisition was similarly in the different times that we acquired those values. So that means that this technique gives us reproducibility of and fidelity of the data that we are acquired. We also wanted to know that if this technology, these tools that the software has itself to measure the values, were similar to those acquired manually by the expert, in this case, Dr. Rao. So we found that there was a very good correlation, no differences between the expert and the software values. So that's something good because we can now trust in this and in those values coming from the specialized tool that we have in this software. But what we found also is that with using this technology, we found almost 67% of dysenergic patterns. And when we inflate the balloon up to 60 cc's, it decreased to 33% for dysenergic pattern. So that means that maybe this technology, I mean, Jung showed us previously that the dysenergic pattern in healthy controls can be present, but I think for this technology we have to be very careful because it's showing a higher prevalence of these patterns even in asymptomatic voluntaries. Another Korean study with 54 healthy controls, half of them male, they found similar results that we have, so higher pressures in the resting and the squeeze pressure, but differences in the bearing down maneuvers between males and females. So the males, they have higher values and also volumes for the rectal distensions and sensations. So what is this 3D high definition anorectal manometry good for? Well, let's talk about some clinical utility. So we can assess now very good the resting pressure and the squeeze pressure, and we can see this asymmetry, and we can actually value how is the pressure located in the entire anal canal. We can also assess this bear down maneuver, and we can see nicely how it's relaxing, but something that I think Adil has telling us in previous studies is that with this technology, with so many sensors in the rectal canal, in the anal canal, sorry, so the relaxation is not as we figured it out in the past, it's not complete. It's making some relaxation, but it's not entirely relaxing. So it's not meaning that there's a bad relaxation, but maybe it's that because there are other components that we are not measuring, as for example, soft tissues or hemorrhoids or vascular things that give us a persistent pressure even when the patient is doing a very good pushing effort. So also we can do the Valsalva maneuver and see how is this cuff reflex, and we can assess the rectoanal inhibitory reflex when it's in a good manner or where it's lacking in a response, which is anorectal areflexia. And also we can categorize this maneuver, the pushing maneuver, and we can see if there is this dysenergic. And also, more interesting is that we can see which part of the anal canal are doing the paradoxical contraction in this case. This 3D also gives us an opportunity to assess the pelvic floor. So with a pushing effort, we can see that the lower margin of the anal canal, the anal pressure, the lower aspect of the anal pressure goes down during the pushing effort. So with this, we can measure now, and this displacement that this lower margin have. And so we can assess if there is an excessive descent or is a normal descent. So more normative values, we need to have a better picture of this. Also, components of the pelvic floor pathology we can see with this 3D high definition manometry. So here in the upper part of the anal canal, we can see an increase in pressure once the patient is doing a pushing effort. So, and you can see that this increase in pressure is above the upper margin of the anal sphincter pressure zone. So that means that something is making contact with the probe in the upper aspect, so meaning that it is a rectal prolapse. And this is the same for the rectal intussusception, because there is also a mark that is above the upper part of the anal sphincter, and is also a big movement of the or an excessive descent of the pelvic floor. So everything together, I mean, it can be assessed with the 3D high definition anorectal manometry. Also, we can see outcomes, for example, after transsphincteric myotomy for an anorectal fistula. So here we can see like a defect in the pressure going down, and after this treatment, so we can now assess how profound is the damage in the anal sphincter. And talking about that, I think one of the more important utility of this technology is to assess sphincter defects. So in this study assessing 221 patients, the defects of the anal sphincter and the pulp rectalis were detected and rated by 2 experts. So almost 30% of patients, they have fecal incontinence, and the defect was found in 19% of the patients. But importantly, when the rating by the 2 experts was performed, it was poor. The kappa values that you can see here is 0.3, 0.4 at most. So I think that the the way that we are perceiving these defects is something that we need to talk and to better understand. In this other French study, they found a prevalence of 22% of these sphincter defects with this sensitivity and specificity when was compared with the healthy controls. But now, what are we comparing with? So we need to compare the 3D high definition with the more structural assessment with the endoanal ultrasound. So this study assessed the measurements and the resting pressure and the squeeze pressure using the 3D high definition manometry compared with the 3D anal ultrasound. So the percentage of defects found by the 2 technologies were kind of similar, but at the times it comes to see the concordance between both studies, I think the concordance was lower, and as is assessed with these kappa values. So I think it's something that we need to define better. How is a defect measured in the 3D compared to the one that we found in the anal ultrasound? This other study assessed these sphincter defects in the patients with fecal incontinence with or without defects. So as you can see, the normative parameters that we have for measurements are kind of similar, but when it comes to the rate of detection of sphincter defects, the 3D detected 14% of those defects compared to the 21% in the anal ultrasound. And more of that is that when they wanted to see if the defect was in the same place located with both technologies, I think the defects was detected in different parts of the sphincter using the 3D compared to the anal ultrasound. In Mexico, Jose has done another study with 88 patients, mostly females. So the rate of detection of anal sphincter defects with the anal ultrasound was close to 60%, while with the 3D was 37% around. And the concordance between these two studies was 58%, with the kappa similar to what has been presented in the other studies. So, and the other thing that I wanted to show you is to see if this is better compared to the high-resolution anorectal manometry, because we always want to have the best. And I think Adil's I found this study, Adil's study, that is the only one I found. It's comparing the 3D compared to the 2D anorectal manometry, and here the resting pressure and the squeeze pressure between high definition and high resolution manometry is quite the same, but it's not the same when it's doing the pushing effort or the bear down maneuver. They also compared the reproducibility of this 3D technology, and they found that also for resting pressure and for the squeeze, it was very, very similar by doing this study in different days and the same patient. So they come with the conclusion that this technology correlates with the high-resolution manometry, but there are some subtle changes that we have to take into account. So to summarize, the 3D high-definition manometry provides us with information about the anorectal physiology and has helped to a better understanding of the anorectal function. I think it's the most important contribution of this technique at this time. There are normative values, but we need more robust information because, as Jose said in his previous talk, I mean, even for high-resolution manometry, there is a lack of normative data, and we need more and big data to better understand what is the normal values in this technology. Morphological assessment of anal sphincter is possible, but the concordance with other techniques is low. And the value for diagnosis of dyssynergic defecation is unclear with this technology, so we have to use it with caution. There is no data to support its use as a therapeutic tool for the biofeedback in dyssynergic and fecal incontinence. That's the reason I didn't show anything about it. So when it comes with the comparison, now we're close to Italy. So we have this very good Fiat at the left, and it's comparing with the Formula One Ferrari that we have here. So is that the same? I don't think so. But is this high resolution, high definition mixture the same also? I don't think so though. So because there are things that we need to put all around and to better understand what is happening with this technology. Thank you very much.
Thank you for that superb talk. Dr. Santoro?
Let me ask before you. So, no, regarding the comparison between ultrasound and manometry, I think that is the concept behind the study is wrong. I mean, you are comparing, not you who did the study, you're comparing a morphological test with a functional test. I mean, you can compare ultrasound with MRI, with other techniques. I think you can compare maybe manometry with EMG, okay, that in some aspect are functional tests. But you cannot compare apple and orange, and to compare ultrasound and manometry is apple and orange, in my opinion, because you cannot have any idea on functionality with ultrasound, because what you see, you can even have a damage, but you have normal manometry in some patient. You can have a normal, apparently normal sphincter, but doesn't work and with low pressure. And on the other side, you cannot validate a 3D manometry to check a defect with ultrasound, where you don't know what you see as a defect is really a defect. So I think it was predictable that the results were poor.
No, I completely agree. I completely agree. And once I was hearing your lecture, I was thinking, what are we measuring actually? Because I mean, so many muscles, the complex is important.
And as you say, the functionality and values that you have are only due to the sphincter. No, are not only due to the sphincter, but all the other muscles that contribute together to have that kind of pressure.
Completely agree.
I have a quick question for Dr. Santoro. Okay, and you mentioned the fact that the anterior part of the external anal sphincter
is
shorter in women than in men. How confident are you when you see that very short sphincter, whether that's an anatomical variant versus a defect that you're missing?
Yeah. Again, most of the studies that we did were validated by the cadaveric dissection. Okay, so we measured and then.
Sorry, my question is in practice. In
practice, okay. We know that there is a range of normal thickness that is around 15 to 20, 22 millimeter. And this is very important, it's a very good question, in female with incontinence, that apparently they have a normal sphincter on a 2D image. But when we rotate the cube and we measure, we found 4 millimeter, 6 millimeter thickness after sphincter repair.
Sorry, I'm not referring to thickness. I'm referring to longitudinal extent.
To the extent we are confident it is 2 centimeter.
Thank you.
Yeah, in male is 3 centimeter.
Thank you.
And 3D adds and give you the possibility really to measure.
Thank you.
Okay. So I'm very grateful to your chairs for hosting this excellent session. I'm sure you agree it was innovative and really a deeper dive into this area than you would otherwise see.